Hello everybody, this is Dr. Muhammad Yassin, lecturer of anesthesia, surgical intensive care and pain management, Cairo University, diplomate of European Society of Anesthesia and Intensive Care, and fellow of the College of Anesthesiologists in Ireland. Our topic today will be the amniotic fluid embolism. However, the amniotic fluid embolism is a rare clinical condition and its incidence is about 1 to 2 in 100,000 of cases, but it is a fatal clinical condition. It is a major cause of maternal collapse and it is the fifth most common cause of maternal mortality following thromboembolism, bleeding, maternal suicide, and pregnancy-related sepsis. We will discuss the amniotic fluid embolism in a context of clinical scenario. Here we have a multiparous woman who was admitted post-term with a spontaneous rupture of membranes and meconium-stained liquor. A syntocinon infusion was started and she was in early labor. Within an hour, she was contracting strongly and began involuntary pushing. The fetal heart rate dropped, she became distressed and breathless, then cyanosed and unresponsive with seizure activity. So what will be your initial management? This is an emergency situation as you have a pregnant collapsed mother and a fetal distress. So you have to approach this case by ABC approach. Regarding A, this is the airway, so you have to maintain airway patency. If the patient needs endotracheal intubation, you have to intubate this patient by rapid sequence induction and cricoid pressure. Regarding B, I will examine the respiratory rate, I will auscultate the chest, and I will examine the SpO2 using the pulse oximetry. Regarding C, I will assess heart rate, blood pressure for instability. I will insert intravenous cannulae for resuscitation. I will call for senior anesthetic and obstetric help whenever it's possible, and then I will request laboratory investigations. Firstly, I will request CBC for hemoglobin level, maybe there is bleeding. For white BCs, maybe there is leukocytosis related to pregnancy-related sepsis. Coagulation profile, maybe this patient has coagulopathy or DIC that may be a cause of the maternal collapse or a result of a cause that results in maternal collapse. For example, amniotic fluid embolism, which can cause DIC as a sequelae. Liver and kidney function to assess for end organ damage, arterial blood gas to assess for the metabolic and respiratory status, cross-matching for possible need for transfusion, and electrolytes for any electrolyte imbalance. So what is the differential diagnosis for maternal collapse? There are obstetric causes and non-obstetric causes. The obstetric causes includes eclampsia. Eclampsia can cause maternal collapse by different mechanisms, like it can cause severe hypertension and left ventricular heart failure and pulmonary edema. It can cause cerebral edema and intracerebral hemorrhage. It can cause massive bleeding due to rupture liver in cases of HELLP syndrome. So this is one of the obstetric causes of maternal collapse. Secondly, the acute bleeding. The acute bleeding can be due to maternal coagulopathy, for example, or due to any other cause like uterine rupture, placental abruption, or placenta previa. Lastly, the peripartum cardiomyopathy. It is an entity of cardiomyopathy that affects the pregnant woman peripartum, and it is a form of dilated cardiomyopathy, and it is very common due to induction of anesthesia that you have a collapsed or arrested mother. However, these mothers may don't have any medical history that refers to any cardiac problem, as dilated cardiomyopathy causes clinical manifestations that's very similar to the manifestations of pregnancy, like dyspnea, orthopnea, and so on. These cannot be different from the pregnancy manifestations, so most of these cases are not diagnosed before delivery. Regarding the non-obstetric causes for maternal collapse, this is amniotic. There is amniotic fluid embolism. This is our topic today. Pulmonary embolism. The pregnant woman is hyper coagulable, so may suffer pulmonary embolism. The pressure of the gravid uterus on the IVC can lead to stagnation of blood on the lower half of the body, and this can lead to deep venous thrombosis in the lower limbs that can cause pulmonary embolism. Acute myocardial infarction, sepsis, local anesthetic toxicity. This will be revealed by a history or anesthetic history if this patient has an epidural in situ and was injected by local anesthetics, high doses of local anesthetics. If there is intravenous placement of the catheter, this can lead to local anesthetic systemic toxicity. Anaphylaxis, if this patient had any medication, administered any medications that can cause anaphylaxis, or transfusion. So the lab results show that hemoglobin level is 12 grams per deciliter, INR is 3.5, platelet count is 20, ABG pH is 7.2, PaCO2 is 25 millimeters mercury, PaO2 is 60 millimeters mercury, and arterial saturation is 91% on FiO2 of 100%. So what is the most probable diagnosis? As we see here, there is no sign of bleeding, there is coagulopathy, there is elevated INR and low platelet count, there is metabolic acidosis associated with low PCO2 as compensation, and there is hypoxia. The BF ratio is about 91. So what is the most probable diagnosis? It's mostly the amniotic fluid embolism. This is based on the clinical manifestations presented in this case and the risk factors that's highlighted in the case scenario, and we will talk about it now, and regarding the laboratory results. So how do we diagnose the amniotic fluid embolism? So acute maternal collapse with one or more of the following features, like acute fetal compromise, cardiac arrest, cardiac rhythm problems, coagulopathy, hypotension, maternal bleeding, premonitory symptoms that precedes the clinical condition like restlessness, numbness, agitation, tingling, seizures, and shortness of breath. The pathogenesis of amniotic fluid embolism include mechanical and immune-mediated therapy. The mechanical theory, this refers to the embolic effect of the amniotic fluid on the pulmonary circulation that leads to acute elevation of the pulmonary arterial pressure and acute right ventricular dysfunction. This is usually followed by the immune-mediated reaction, which resembles the anaphylactoid reaction associated with leukotriene, prostaglandins, antihistamine release that leads to cardiovascular collapse. So the amniotic fluid usually contains fetal particles like lanugo hair and cells, squamous cells, and this can reach the systemic circulation through any breached vessel. So when it reaches the pulmonary circulation, leads to pulmonary embolism and pulmonary collapse, and as a complication of amniotic fluid embolism, DIC can ensue and can lead to ARDS. Regarding the anaphylactoid reaction, this can lead to vascular collapse. The activation of platelet activating factors and coagulation pathways can lead to DIC and prolonged postpartum bleeding that can be aggravated by the uterine atony. So what are the risk factors? The risk factors are induction of labor by oxytocin, assisted delivery, cesarean section, maternal age more than 35 years, male fetus, polyhydramnios, eclampsia, meconium, uterine rupture, cervical injury, placenta previa, and placental abruption. In our case, this patient was induced by sontisinone. She had a maternal age more than 35 years. She has polyhydramnios and she has meconium stained liquor. The clinical features based on the incidence, the most common are hypotension, fetal distress, and hypoxemia due to pulmonary edema or ARDS, and seizures and DIC can be complications. After initial stabilization, the patient collapsed suddenly with absent carotid pulse. What will be your further management? The cardiac arrest in a pregnant woman has some differences from the cardiopulmonary resuscitation in any other patient. Regarding the start of CPR, we should start CPR, we should attach the defibrillator, but we have to place the mother in the left lateral tilt position. If this is not feasible, we can do manual left uterine mobilization. And we have to consider the endotracheal intubation earlier because this patient is at risk of aspiration. So if this airway is left unprotected, so this patient may suffer from pulmonary aspiration after return of spontaneous circulation. The second part is the high physiological demands for oxygen for mother and for the fetus. So early endotracheal intubation whenever possible after the arrival of the resuscitation team is recommended. After 4 minutes of CPR, if the patient does not reveal manifestations of return of spontaneous circulation, we have to take a decision of delivery, and the delivery should be done in the site of cardiac arrest, and within 5 minutes the baby should be outside the mother. This will improve the chances of the mother for resuscitation and improve the chances of the fetus for survival. So after return of spontaneous circulation, the patient was transferred to the intensive care for further management. What is the problem list of this patient? The problem list of this patient is first the hypoxic injury of the brain, the hemodynamic instability and cardiovascular collapse, the ARDS, the DIC, and uterine atony. So what will be the treatment options? The treatment options will be mostly supportive. We will manage the ABC approach. I will maintain the perfusion. I will maintain the resuscitation, and I will maintain the mean arterial pressure using vasopressors or inotropes based on the cardiac output monitors if it is available. Regarding the respiratory system, I will implement the protective lung strategy. And regarding the DIC, I will follow up the coagulation profile and the complete blood count, and I will improve the coagulation profile using the fresh frozen plasma, the cryoprecipitate, activated factor 7. I will use hemostatic agents like tranexamic acid. Regarding the risk of postpartum bleeding and uterine atony, we have to use ecbolic agents and uterotonics like syntocinon and carbamate to maintain uterine contraction. If this is not effective, I will try to do uterine massage, and if all these measures failed, I will try to refer this patient to OR back again for either embolization guided by the radiological intervention, or by ligation of major vessels, or lastly hysterectomy. So this is all about the amniotic fluid embolism. I hope this is clear. If anyone have any question or query, don't hesitate to contact me, and thank you.